the director of the Kansas Center of Biostatistics and Bioinformatics shared resource. And today she's going to give our last lecture on dealing with delayed toxicity outcomes in phase 1 clinical trials.
Okay, thank you, Andrew. Share my slide. So can you see that okay?
Yep.
Okay. Yes.
Okay, let me see. I like to use the pointer. So like Andrew said, I'm Dexiang Gao. I'm a biostatistician and the co-director of the Kansas Center Biostats and Bioinformatics Shared Resource. So this is going to be the fifth and the final lecture in the phase 1 clinical trial series. The topic of today's presentation is time to bone design. So here's the outline of my topic, my talk. So I will first review the phase 1 clinical trial designs that my colleagues have presented in the previous 4 lectures. And today I'm going to focus on the late onset toxicity. And the phase 1 designs, which can accommodate late onset toxicity to accelerate the trials. And I will give detailed comparison between the rolling 6 and time to bone design. Both are phase 1 designs can accommodate late onset toxicity. I will then focus on the time to bone design in terms of implementation and the outcomes, output. And then I will run through an example using the time to bone design, and then I will conclude today's lecture by a summary. So the objective of the phase 1 clinical trial design is to find the maximum tolerated dose or the recommended phase 2 dose. So the MTD is the dose with the dose limiting toxicity probability closest to the target DLT rate. For example, a target DLT of 30% is desirable for a new drug for a population without effective treatment. It's a little bit high. In the end of the phase 1 trial, it shows that the dose 1 and dose 2 have a DLT of 10%, and dose 3 has a DLT of 28%, and dose 4 has a DLT of 35%. Then the 28% from the dose 3 is the DLT. So again, here is the review of the designs that my colleagues have covered. So the phase 1 design have 3 types. One is a rule-based, another one is model-based. And the relative newer design is the model-assisted design. The model-assisted design actually combines the good characteristics of the rule-based and the model-based. So the 3+3 design is a classic rule-based design. We also call the rule-based design as algorithm-based design. So the rule-based design is simple and transparent. That's the good advantage. However, the rule-based design is inflexible and it has low accuracy for MTD, and it can treat a large patient as low dose or suboptimal doses. And we are unable to specify a particular DLT if we use the rule-based design. The continued reassessment method, CRM, is a classic example of the model-based design. It's well-performing. So the dose and toxicity relation are modeled. And it's not, or more importantly, that the relationship is or the model is repeatedly updating based on the new information from the trial. Because of that, it is considered complex or closed box. The model-assisted design, on the other hand, is well-performing and is simple and is transparent. So both the BOIN design, BOIN, and the keyboard design that my colleagues have covered are the examples of the model-based design. In addition to being simple and transparent, it also has great characteristics. For example, it's flexible. We can customize the target toxicity rate and the cohort size. In addition, the cohort size can be adaptively changed. So those are just the reviews. So the late onset toxicity is common for novel molecularly target agents and the immune therapy. To accommodate late onset toxicity, we in general use a relatively long toxicity assessment window. For example, the assessment window can be over multiple treatment cycles. For example, without late onset toxicity, the toxicity window can be as short as two weeks. However, with late onset toxicity, the toxicity window in general is 8 weeks or more. So with a long toxicity assessment window to actually to capture all the DLT relevance for dose escalation and MTD determination. However, there's logistic difficulties with long toxicity window. Here is an example. If the DLT takes up to 8 weeks to evaluate, and the accrual rate is 1 patient per week. So here is the time in week, and here's the DLT window is 8 weeks. So suppose we treat 3 patients. However, during the time to complete the DLT access for the 3 patients, we will have 8 patients available. So a possible solution to overcome this, the problem with the long toxicity window is that we suspend accrual after each cohort and wait till the DLT data are cleared for this accrued patient, for this treatment patient. However, repeated interrupting accrual is highly undesirable and is infeasible in practice. So the question is that how can new patients receive timely treatment when the previous patient's outcomes are pending or their DLT's evaluations are pending? The same issue arises when the accrual is rapid. We have a lot of patients accumulating there waiting to be treated. However, we have to wait, right? So that's the big issue. So what then we need are phase 1 designs allowing for continued accrual and the real-time dose assignment for new patients when some previous patients' DLT data are still pending, thus to accommodate long toxicity window and accelerate phase 1 trials. So here I'm going to talk briefly mention 3 phase 1 designs, which can accommodate the late onset toxicity and the accelerate trials. So the rolling 6 design is a modification of the 3+3 design, which allows for continued accrual up to 6 patients to a dose level when some of the patients' DLT data are still pending. So we call those patients with their DLT data pending as pending patients. For example, if 3 patients have been treated, 1 or more pending, or 1 DLT observed, then 3 new patients can be accrued to treat it at the same dose without have to resolving the pending patient's DLT. If there's 3 to 6 patients have been treated, 2 or more DLT observed, then the next cohort will be de-escalated without have to waiting for the pending patient's DLT being complete. However, accrual to the study will be suspended when waiting from data from all 6 patients, if there's no DLT there, because then we, to avoid the risky decisions without much information. So another design is time to CRM, which is built upon CRM. Is a model-based design, which allows for continual accrual and dose escalation decisions while some patient DLT data are pending. The time to CRM accomplishes that by imputing the DLT outcome for the pending patients. In addition, the time to CRM allows the dose allocation for subsequent patients based on all the previous patients' information, including the observed DLTs, number of pending patients, and the total follow-up times of all pending patients. The time to bond design is another design which can accommodate late onset toxicity, which is built upon the bond design. The bond design is a model assisted design. So the time to bond design allows for continued accrue and the dose escalation decisions while some patients' DLT data are still pending. Similar to time to CRM design, the time to bond design accomplished thus by imputing the DLT outcome for pending patients. And similarly, it's the dose allocation for subsequent patients are based on all the previous patients' information, including the observed DLTs, number of pending patients, and the total follow-up time of all pending patients. So now I'd like to provide a little bit detailed comparisons between the rolling 6 and time to bond design. So the first one is the DLT rate. So the DLT rate for rolling 6 is actually in the range of 17% to 26%. This is obtained through extensive simulations. Because the DLT rate actually is in the range, we cannot actually target a specific DLT rate for our trial if we want to use the rolling 6 design. However, for time to bond design, we need to specify a DLT rate. For example, if there's not effective treatment for a particular cancer patient, then we can specify a relative higher DLT, for example, 30% DLT. Also, for example, if there's some treatment options, then we can, for a new treatment, we can specify a relative low toxicity or DLT for treatment, for example, 20%. So this is a lot, and we need to specify that. The cohort size for rolling 6 is most time is 6. However, if it's extremely toxic, for example, when 3 patients are enrolled, there's immediately there are 2 DLT, then we stay to 3 to 3. However, there's no other choice for the cohort size beyond the 3 or 6 for rolling 6 design. The time to bond design allow customizing the cohort size. For example, if we use accelerate titration method, we can start with a cohort size of 1, and then we gradually change or adaptively change the cohort size to 3. And also the time to bond design allow the deviation from the plan. For example, if the plan is to have a cohort size of 3, however, due to some reason we lost, some patients are lost to follow-up, then it's no problem for time to bond design. So it's very flexible. The MTD determination for ruling 6 is this. So when there's 2 or more out of 3 to 6 experience a DLT at the next highest dose, then the dose with 0 to 1 DLT out of 6 is the MTD. So then you can understand why the DLT is a range for the ruling 6 design, because it's, this is just based on this rule. There's no calculation, nothing. So you cannot, that's another reason you cannot pre-specify a DLT rate. To determine the MTD, the time-bound actually, time-to-bound design will pull all the information across the cohorts to make the determination. The sample size for MTD decision, again, as I have elucidated, that is only allow 6 patients. We know that 6 patients will provide not much information. Actually, it's too little information for MTD determination. The reason I say that is as this: if there's 1 out of 6 patients experience DLT, although the point estimate is 16.7%, however, the 95% upper limit can be as high as 64.1%. That means although we have 1 out of 6 experience DLT, however, the DLT can be as high as 64.1%. That's scary. And if there's 6 out of 6 patients experience DLT, although the point estimate is 50%, however, the 95% lower CI can be as low as 11.8%. So although, the MTD, when we use the ruling 6 design, if there's 3 out of 6, we immediately reject the dose. However, that toxicity level can be as low as 11.8%. The reason is because 6 patients, you don't have much information, so the confidence interval is extremely wide. So the time-to-bound design allow us to pre-specify the maximum sample size, so we will have adequate sample size for the MTD determination. In addition, we can pose a stopping rule when MTD is reached. Thus, we can save patient resource and unstop the trial. However, this need to be done during the design phase. As I mentioned, that the ruling 6 and time-to-bound design both can accommodate late onset toxicity and accelerate the trials. The ruling 6 doing that by count the number of pending patients. However, it does not consider the follow-up time of the pending patient. We know the follow-up time actually contains rich information in terms of the DLT. For example, if a pending patient who is 3 days away from completing DLT assessment is less likely to experience a DLT than a pending patient who has been followed for only 3 days. So the time-to-bound design not only count the number of pending patients, but also use the follow-up time of pending patient to make efficient decision of escalation and the de-escalation. Risk of over and underdosing. The ruling 6 design, again, you see that from the MTD determination is overly conservative and has poor precision to identify the MTD just because it's only allowed 6 patients. The misidentification of MTD has serious consequences, which can treat large number of patients in phase 2 at overly toxic or subtherapeutic doses. So the time to bond design actually balance between the safety and identifying the MTD. So in this slide, I put the rolling 6 and the time to bond as well as time to CRM into our design frameworks. That's the 3 different types of design. So rolling 6 again is a modification of 3+3 design. It's a rule-based or algorithm-based design, which allows for continual accrual of up to 6 patients. It's just like the 3+3 design. It's a simple and transparent. The decision rule is pre-tabulated, or actually is invariant to any trial we're going to use if we use the rule on the rolling 6 design. However, the drawbacks is that it has low accuracy for MTD. It can trace a large patient as low doses or suboptimal doses, and occasionally it may be overdosing. And if we use this design, we will be unable to specify a particular DLT. The model-based design time to CRM is the example, which allows for continual accrual and the dose escalation decisions. Is well performing just like the CRM design, as it's built upon the CRM. The difficulty with time to CRM design to clinician is that it's a model based. So the trial statistician need repeatedly run the model to update the model parameter or update the model. So it's considered a complex or close the box by clinicians. So the model assisted design, the time to bond is a model assisted design. It also allows for continual accrual and dose escalation decision. It's well performing as model-based design, and is also transparent and simple to implement as rule-based. We can pre-tabulate the decision rule before we start the trial. It is flexible and efficient, which allow customizing the target toxicity rate and the cohort size. In addition, the cohort size can be adaptively changed. So here I pick up the design characteristics. So we have, again, we have, a better emphasize the difference between the 3 designs. So first one is that, can it target any pre-specified DLT rate? The answer is no to rolling 6 design, because the toxicity rate you obtain after running trial is a range. So there's no way you can pre-specify the DLT rate. However, that's not true for the time to CRM, time to bond design. We need to specify a DLT rate before we start design the trial. Allowed to use a cohort size other than 3. So the rolling 6 allowed to use 3 or 6, but there's no other choice for the cohort size. However, the time to CRM tied to bond design both allow flexible cohort size. We can choose a cohort size of 1 or 3, or we can have different cohort size when we run the clinical trial. So use follow-up time data from pending patient to make efficient decisions of dose escalation and de-escalation. That is no to rolling 6 because it's only count the number of pending patient. However, that is true for time to CRM and the time to bond design. Can sample size be calibrated to ensure good operating characteristics? The answer is no to rolling 6 because it's only allow 6 patients on each dose. So there's no way you can calibrate the sample size. And however, time to CRM, time to bond design both allow us to pre-specify the maximum sample size. Thus, we can have a adequate sample size for the MTD determination to ensure good operating characteristics. Can the number of patients treated as a MTD to be more than 6? Is no for rolling 6. However, that is true for time to CRM and the time to bond design. In general, we have many more sample size at the MTD dose. Can dose escalation, de-escalation rule be pre-tabulated for simple implementation? That is true for rolling 6 because the advantage of rolling 6 is simple to amplify, and we can pre-tabulate the decision rule. Now, that is also true for time to bond design. However, it's not true for the time to CRM. As it's a model-based design, we need repeatedly running the model to update the model or the parameter. Require complicated repeated estimation of the dose toxicity curve model. Yes, that's true for time to CRM. However, that's not true for rolling 6 and time to bond design. So now I discuss the implementation of to-bond design, so time to bond design. So what we need is that we need the maximum number of patients. We also need to put in the desired cohort size, although the cohort size does not need to be always the same. We can start with cohort size 1 and then later on change to 3, but we need the design the cohort size. In addition, we also need to specify the target DLT rate. In addition, we need to specify the acceptable DLT range, which is defined by phi1 and phi2. So phi1 is the highest DLT rate deemed underdosing. So this will be used for escalation. There's a default value, which is 0.6 of the DLT. And the phi2 is the lowest DLT rate deemed overdosing. So this will be used for de-escalation. The default value is 1.4 times the DLT. However, we can customize the DLT range. We don't have to use the default value. It's just in general, the default value perform well. To accommodate the late onset toxicity, we need to impute the DLT outcome for pending patients. So the total follow-up time is the sum of follow-up time for all the pending patients at the current dose. For example, there's 3 pending patients with follow-up time at 45, 30, and 15 days. Then the total follow-up time will be the sum of the 3 numbers, which is 90 days. The standardized total follow-up time is the total follow-up time divided by the DLT window. For a DLT window equals to 90 days, then the standardized total follow-up time will be 90 divided by 90 equals 1 for this example. So the dose escalation and the de-escalation rule depends on the observed DLTs, the number of pending patients, and also the standardized total follow-up time. So use the standardized total follow-up time has the advantage that is invariant to the DLT window. Thus, we can pre-tabulate the decision rule without need to worry about the trial has a long DLT because it's standardized by the DLT. In addition, to ensure the safety, we put accrual suspension rule. That is that suspend the accrual if no DLT, and there's 50, then more than half of the pending, there are more than half of pending patient at the current dose. To avoid risky decisions just because of the sparse data there. The second safety rule we impose there is that if the probability that the observed DLT is greater than the target DLT with the probability greater than 0.95, then the current dose and the higher dose will be eliminated. If this dose happen to be the lowest dose, then the trial is terminated. That makes sense, right? If the first dose is really toxic, we should immediately stop the trial. So this is the output or the pre-tabulated de-escalation and the escalation rule for a trial with a target DLT rate of 0.2 and a cohort size of 3. You see that the number of patients treated and the number of DLTs and the number of pending patients and the standardized total follow-up time are the component for the dose escalation and de-escalation rule. Select MTD. So this is just like the bone design, that the MTD is selected by computing isotonic regression estimate of toxic probability. Then we choose the estimate closest to the target DLT. And if there's ties, then we select the highest dose that is less than target. This is just because the underlying hypothesis is that the higher dose level, higher potent of the drug. Here is an example for selecting the MTD. Suppose we have 5 dose levels, and after the trial, the estimate DLT for dose 1 and dose 2 is 0.02. And dose 3 is 0.27, and dose 4 is 0.45. And the target DLT is 0.3. Thus, the dose level 3 or the 0.27 is the MTD for this trial. So now I'm going to run through an example using the time-to-bone design. So here's the trial design information. So the target DLT rate is 0.2, and the DLT assessment window is 3 months. And the accrual rate is 2 patients per month. We have 5 doses, and the cohort size is 3. The maximum expected sample size is 30. So that's the pre-tabulated decision rules based on the information we just put in. Here is the trial. So the trial start by treating the first cohort at the lowest dose level. So here, each circle represents a patient. And remember sorry. So the blue circle is no DLT, and the orange circle is the patient with DLT. And the X is the time to DLT. Remember that the trial has accrual rate of 2 patients per month. We assume the accrual rate is uniform distribution. So to accrue 3 patients that need 1.5 months. And the DLT window is 3 months. So after we accrue the 3 patients, and since there's no DLT, so we, based on our imposed safety rule, we suspend the trial until we have over half the patients DLT evaluated. So that will be by month 4 or at day 120. So we look at the decision rule here that 3 patients treated, no DLT. We have 1 patient pending. So the decision is to, yes, escalate. So the next cohort patient will be treated as dose level 2. By day 150, there's 1 DLT. So we look at the decision table that 3 patients treated, there's 1 DLT, and then there's 2 pending patients. So the decision rule says de-escalate. So we de-escalate the third cohort to dose level 1 here. By day 210, when the number 10 patients is available, we have already treated 6 patients, and among them 3 patients DLT have been fully assessed, and there's no DLT. So 6 patients treated, no DLT here. There's 3 pending patients. So the decision rule say escalate. So that's we treat the patient number 10 to 12 at the dose level 2. By day 255, when patient number 13 arrives, we have 1 DLT at 150 days. So 6 patients treated, 1 DLT, 6 patients treated, 1 DLT. And then there's 3 pending patients. So the rule says stay. So the patient number 13 to 15 are treated as dose level 2. So at this time, by day 300, that we are treating 6 non-patients as dose level 2. Among them, we have these 3 patients DLT totally observed, and then we also have patient number 10 observed, because you can see that here is 1 month, 2 months, and then 3 months. The DLT assessment is 3 months. So the patient number 10 by the when at the day 310 is already observed. However, if we look at the decision table here, that we need suspend we need suspend accrual. The reason is that although we have 1 DLT, however, we don't have, we only have 4 patient DLT observed. We have 5 pending. So by 315 days, then we have non-patient treated. We have 1, 2, 3, 4, 5 patients DLT fully assessed, and we have 4 pending patients. So we look at the decision rule here. We have non-patient treated, we have 1 DLT, and we have 4 patients pending. And the decision rule says the decision will depend on the standardized total follow-up time. So we calculate the standardized total follow-up time for the pending patient 12 to 15. The standardized total follow-up time is 2.33, so which is greater than 2.15. So the decision rule says escalate the next cohort. So by day 315, we escalate the patient number 16 to 18 to dose level 3. At day 327, there's 1 DLT. So 3 patients treated at dose level 3, 3 patients treated, there's 1 DLT, there's 2 pending patients. So the decision rule says de-escalate. So the next cohort patient is de-escalate to dose level 2 again. So at the end of the trial, dose level 2 is selected as MTD, at which there's 4 out of 21 patients had DLT. So there's total 21 patients treated on dose level 2, and there's 4 orange colored, means 4 DLT. So the estimated DLT rate is 0.19, which is close to the target DLT of 0.2. So the trial takes about 615 days or 20.5 months to finish. By contrast, the trial would run about 40 months if we apply the standard adaptive designs that require full DLT assessment before enrolling each new cohort. So summary. So the model-assisted time-to-bone design is both transparent and effective. It has advantages from both model-based and the model rule-based designs. It is flexible, allow for targeting DLT and the cohort size. It supports continuous accrual and allows for real-time dose assignment. Thus, it can accelerate trial. So we strongly recommend the time-to-bone design. Although we also like to do the time-to-CRM design, the model-based design, because that's no issue for us. So we are the Kansas Center Biostats core. If we can assist you with your trial designs of any phases. So although this series is only about the phase 1. In addition, we also provide other services, including assisting in statistics in the grant proposals and also in analysis project. And please contact us with our, okay, sorry. You can reach us at ccbiostatistics@cudenver.edu. So here's the selected resource for my presentation. And thank you, and I'm happy to take questions. I don't know how to. I don't know how to. I can share. Okay. Yes, there's a question in the chat that are you seeing more adaptive designs in clinical trial? Yes, that's true. Actually, last year we attend online phase 1 design for oncology, and we are actually, there's one person from FDA. She strongly recommend the time-to-bone design and the time-to-bone design and the bone designs. So it's like the FDA gave really the green light for the model-assisted designs. Okay, thank you again. If there's no more questions, and also you can reach me through my email or to write email to the CC Biostats at biostatistics@cudenver.edu to reach us. Thank you for attending. Bye.